Hello, everyone. It's an absolute pleasure to welcome you this evening to our webinar. And I just wanted to introduce myself. My name is Dr. Gemignani. I'm the chief of the breast surgery division here at NYU and part of the Perlmutter Cancer Center. And so what we thought all of us would do today is kind of talk a little bit about something that we've been noticing a lot of. And this is these early onset cancers in women and how it affects not only the risk for young women, but also for different types of cancers and some of the strategies that we have that can help with that. And so with that, let's see. So I want to go ahead and address that increasing incidence of cancers that we're seeing in young women, actually in young adults overall. And we want to focus on breast cancer and colon cancer. We want to discuss fertility issues and some options and discuss genetic testing and some high-risk screening that are available for women at risk. So when we think about the problem, researchers report that cancer diagnoses are continued to rise in 15 to 39-year-olds and overall in those less than age 50. And most of that is made up with some other cancers, but also breast and colorectal cancers. Experts say that maybe there's some other factors beyond just genetics that may play a role. Some diet, obesity, and some other lifestyle issues are probably playing a role in all this, and it's hard to define exactly which one it is, and probably a combination of many factors. It's also very important to know that young adults, and this is an important point, do not always seek early medical care, so that if they notice something that they're less likely overall, this is what the research shows, to go see their doctor, or maybe they don't have insurance themselves, and so they tend to be diagnosed a little bit later. And compared with other groups of patients who end up having cancers, we see that the treatments that are necessary for these end up with the group having higher risk of long-term and late effects from treatments. So infertility, sexual dysfunction, cardiovascular disease, and depending on the age of diagnosis, a possibility of future malignancies. So this was a study that was published in recently, and it looked at what is highlighting this problem with the patterns in cancer incidence among young people in less than age 50 in the US. And we see that it's on a rise under age 50, particularly among women. And we do even at the youngest age groups, particularly focusing on things like breast cancer. We see that there is an increase of about 5% from the age group of 20 to 29, and about almost 20% for women in the age 30 to 39. And what's important is that we don't understand why. So although the proportion of women who are getting diagnosed with breast cancer under the age of 40, 45 has remained the same, we're seeing a younger cohort within that same percentage. So it's not that we're seeing more, it's just that we're sometimes seeing it at a younger age. So like I said, no clear explanations why we're seeing this younger age. And so maybe there's a possibility that diagnosis is better and that some patients are getting the benefit of some imaging modalities that are picking them up younger than they would have if they hadn't had that screening. So that's definitely a factor. And we'll talk a little bit about the genetics and family history influencing these cancer risk. Delaying first pregnancy, so it's a kind of a known risk factor that later ages of pregnancy is thought to be a factor in developing breast cancer. And then obviously some modifiable things like diet, obesity, and alcohol consumption have also been associated with breast cancer risk. So just focusing now a little bit on just the breast cancer itself, it's important to remember that when we talk about all women, this is uncommon. So it's not like we're seeing this as a common disease in women less than age 40 in developed countries. If you go around the world in some other countries, particularly in continents, you do see younger age of onsets and a higher percentage of the women that are within that cohort of less than 40. Age is an independent risk factor associated with a higher rate of relapse, what that means is that a lot of young women have more aggressive types of breast cancer, and that their presentations when they're coming in, they're definitely more advanced than the average age woman who's in her 50s, early 60s, who's been screening with mammography. So looking at the incidence, we see that there's a lot of breast cancer, and that's why it's so highlighted that even though the percentage is small, you're still having quite a lot of women. And the more aggressive types of breast cancer, such as triple negative, we like to kind of see more hormone receptor positive cancers, because in those cases, sometimes you can avoid chemotherapy. But in these cancers that are more aggressive, we see them also in a higher proportion of women under age 40. So for example, in the average population, we see that triple negative breast cancer is less than 10%. But when we think about women 45 and younger, that makes up about 30% of those breast cancers. So the other important part of this whole discussion is that we not only have to think about diagnosis and treatment, but we also have to focus on some unique needs of young women. So the fertility and sexual health, genetic risks, psychosocial parts, financial employment. A lot of my patients who come in with this early diagnosis have young children at home. Many haven't even completed education. So it's important to think about support groups and other women who have gone through this, to kind of have that discussion with them. And we all know that when we think about research and clinical trials, which is what changes the outcome for cancer because it provides us with evidence on how we want to practice, we see that younger women are underrepresented. And that's something we definitely want to change. So a lot more prospective research, increasing patient-reported outcome studies, and looking at potential for grants and collaborations. And then finally, the one thing, there's two more things that I want to bring up. The one thing that is very much associated with this is that many times a woman knows that there was something different about the way that their breast felt, but they've gone to some place. And so there's this whole thought process that, oh, you're too young to have breast cancer. And so this leads to a delay in diagnosis. So maybe on the woman's part, didn't go because she didn't even think that this could be an issue. Or maybe she saw a doctor and wasn't like really completely followed through with what that issue was. And that leads to more advanced cancers. And you have to remember, when we think about screening guidelines, we think about women 40 and older. So the women who are under age 40 wouldn't really fall within that screening pattern, which leads to their presentation of what we see. So what should you do? I think it's very important, and we'll talk a lot about this in other parts, but you have to understand your family history. Consider genetic testing if there's something is very particular about your family that has a lot of breast or ovarian cancers, and one of our panel members will go into this in more detail. You have to have a discussion with your doctor and your healthcare provider about your own personal risk, what your family history is, dense breasts, age and lifestyle issues, and discuss whether earlier screening is an option for you, depending on those family history and genetic risk. And then think about modifiable risk factors, exercise, weight, and maintaining a healthy diet with a decrease in alcohol consumptions are kind of things that can potentially shift some of those risks into things that we can actually do and affect outcomes related to that. And I think with that, I'm going to go ahead and turn over. I'm going to stop sharing and go on to our next panelist. Thank you.
My name is Bashar Safar. I am the Chief of Colorectal Surgery here at NYU. Thank you all for joining us. And it is a pleasure to spend this afternoon with you, telling you about some of the stuff that we're very passionate about. And, you know, the group that you see here in front of you, we've discussed these amongst each other a lot. So we decided to put this and share it with you, as well as really hear your perspective and have an open discussion. You're going to hear me repeat a lot of the things that you heard already just now about breast cancer. Why am I speaking about colon cancer in young adults? Well, first of all, colon cancer is the fourth commonest type of cancer in the United States. And there's about 150,000 people who will be presenting, estimated this year, with colon cancer. This is colorectal, actually, in general. This is not just colon or rectum. And I will tell you the distinction here in a minute. This represents about 8% of the overall cancer burden in the country. Now, the average age is 66. So this is a disease of slightly older individuals, but the rise, much like the other cancers in the younger individuals, is very concerning, especially for rectal cancer. So this has actually changed. This is sort of from 2012 to 2016. And I think the most recent data shows that in women who are younger than 50, colon cancer is the second deadliest cancer. And in terms of men, it's the number one for young adults. According to the NCI, the rate of colorectal cancer for patients under 50 has doubled since 1990. And by 2030, 1 in 10 colon cancers will be diagnosed under the age of 50. So 1 in 10. At this point, as you saw from the previous slide, and if I was going to go back to that, it's really represents a 20%, much smaller. This is it. It represents, about 7%. It's going to be more than 10%. And as I mentioned, it's the second leading cause of cancer in women younger than 50. So this is the number of cases that are going to be approximately diagnosed, and that was last year. And it's the same thing. It's about 150,000 a year. There's no different. And this includes about 20,000 people younger than age 50 that will be diagnosed. And the one that's on the rise more so is the rectum than the colon. And I will touch a little bit about why that's more important, especially for young females in a minute. So what are the signs of colon cancer, especially in young adults? Change in bowel habit, rectal bleeding, anemia, and abdominal pain. Unfortunately, rectal bleeding is always gets attributed to hemorrhoids. And I see a lot of young patients who say, oh, yeah, I just had some hemorrhoids and it's not a big deal. When I first started practice, if you were younger than 30 years of age and you had some bleeding and I saw hemorrhoids, I'd say, don't worry about it. We'll band it or we'll treat you for the hemorrhoids and we don't need to really do a colonoscopy. In the current time, really, almost even patients who are in their teens, if you have rectal bleeding, you're getting a colonoscopy. I don't think bleeding is normal at any age in today's sort of paradigm of treatment. The other thing is, can you do other methods of screening? Sure. You can do other methods of screening, but colonoscopy remains the gold standard. These other signs and symptoms also are to be sort of very much, patients should be aware of them. Why is it rising? We don't know. I sort of told you what the problem is. I said, it's a common cancer. It's one of the deadliest cancer in the country. Why is it rising? Really, we have no idea. There are some some research going on into the microbiome, into sort of our environmental inputs, but nobody really knows. And this was an article that was actually published, I think, 3 months ago in the New York Times, and it has very nice summary of a lot of the data that is sort of current. There are a lot of celebrities that we've all sort of seen and heard about recently who have developed colon cancer and unfortunately died from colon cancer. So why do we think it's happening in younger adults? Again, it's really hard to imagine somebody who's in their 20s, which we've seen patients as young as 20s, and in their 30s to have accumulated enough, whether it's dietary or something else to result in cancer. But to be honest, it has to, because these are not genetically based. In colon cancer, we also have some very specific genetic mutations that lead to colon cancer, like something called FAP, which gives you polyposis, or Lynch syndrome, which is HMPCC. These are clearly identified mutations, and they lead to early onset colon cancer. But the ones that we're talking about are not genetically driven cancers. And it's still, there's a big rise, and whether it's to do with the altered gut bacteria, whether it's to do with obesity or metabolic syndrome or dietary intake of more protein and fat, A lot of my patients also ask me, if I change my diet now, is this going to prevent me from having a second cancer? It's very difficult to answer that question accurately and give you a very accurate information. Clearly, the diets that work from a health standpoint that have been advertised for years, which is sort of more fiber, less fat, less red meat, work for everything, for the heart, colon cancer, et cetera, et cetera. But I don't know if just changing the diet would have been enough to prevent this problem. This was just published again May 10th, which um, which is really scary. I mean, this was diagnosed with stage 4. There is some evidence that younger patients are presenting with more advanced disease and it's more aggressive disease. Again, it's difficult to know if this is due to delayed diagnosis, because when you're young, you say, I'll just have a little bit of pain or write off some bleeding, and that's why you're presenting with stage more advanced disease. And there's a lot to be sort of uncovered still in this field. Something went off with my next slide. So what about the recommendations? It used to be, this is the U.S. Preventative Services Task Force. It used to be that this age of screening for colon cancer was 50 and above, and it's a colonoscopy. If the colonoscopy is normal, you don't need another one for 10 years. And there was some recommendation to sort of stop the screening at the age of anywhere 76 to 85. I have to say, at both extremes, I'm not sure I agree with the recommendations. Definitely agree with the younger recommendation now at 45, but we see a lot of patients who are very fit and well into their senior years. And if you're well enough to have an operation, I don't see why, if you have some of the symptoms I mentioned above, you shouldn't get a colonoscopy. I guess at that point, it's not screening, it's diagnostic, but still, if somebody's had a cancer or a very strong history, they should probably continue getting scopes. Just a brief note on staging. Everything in cancer, whether it's breast, endocrine, GYN malignancies, or colon, is driven by the stage. The earlier the stages, the more curable the cancer is. Stage 1 and 0 cancers in colon are very much curable. Surgery alone takes care of it. And generally speaking, that's where we want to find things. It's a polyp, you get a colonoscopy, it gets removed, and you just get to put on a surveillance program. As you progress through this, which in colon cancer, the way that we stage things is how deep the cancer has gone into the wall of the bowel, and then if there are any lymph nodes involved. If there are any lymph nodes involved, it makes it a stage 3. If it's gone distant, it makes it a stage 4. Distant mets typically go to the liver and to the lung. We still treat patients with curative intent, even for stage 4, if it's limited liver disease. And even for advanced, sometimes liver disease, we have protocols where we would offer, or we would list a patient for a liver transplant, with again, the hope of curing the disease if it's limited to the liver. So in summary, the stage is determined by how deep it goes into the wall, and then it goes from the wall. Typically, it goes to the lymph nodes, and that's the first stop, and then it goes distant. So what's specific about rectal cancer? It's thought to be the reason why cancers are increasing. Colorectal cancer is increasing in younger adults. It's thought to be responsible for that increase. Both men and women, more in men and more in white men, based on the studies that have been done recently. But why is this very important to women? Well, in young adults, this is an age where the finances of it and the quality of life and the part that's sort of the anxiety and all that stuff, I think affects everybody. But what's specific for young females is the concern about fertility, pregnancy, and childbearing, and how a woman will be able to carry through the pregnancy, and as well as sexual function from the radiation, things that we don't really discuss a huge amount on the surgical side. Is, when you radiate in the pelvis, there's a higher incidence of vaginal stenosis. If you radiate the pelvis, could you then carry a child in a uterus that's been radiated? The fertility, for sure, there are a lot of methods, and I think you're going to hear a little bit about all this in a little while. But these are things that are very specific, and we've been very successful, and the team you see in front of you, we sort of all jump in, and we have some medical oncologists that are fantastic that we work with, and everybody is on board, and we're here to provide one team approach for this problem. So we're in the process of hopefully formalizing our center, if you like, for young adults, but it's very much something that we're interested in and focused on. So to summarize, for colon cancer, please get screened at the age of 45. And if you have any symptoms like bleeding, do not ignore it. Do not think it's just hemorrhoids. Make sure that you go see someone and get a colonoscopy. We have very easy access to colonoscopies, both by the surgeons and the gastroenterologists at NYU, and we would love to take care of you. And with that, I'm going to say thank you and turn my presentation to the next presenter. Thank you.
Hi, everyone. Thank you so much for joining us. My name is Emmeline Vicky. I'm a GYN oncologist practicing out in Long Island as part of the Perlmutter Cancer Center. And I'm very delighted to be giving you a little brief talk on fertility sparing considerations in both gynecologic and non-gynecologic cancers. So what we'll talk about really is updates in fertility sparing management for cervical cancer, and also some new novel approaches to preserve fertility for non-gynecologic cancers. All right, so fertility sparing management of cervical cancer. I'm presenting this now because there's been recent updates that have really changed the way that we manage early stage cervical cancer. So traditionally, the candidates for fertility sparing cervical cancer management meet the following factors. We think about patient specific factors and also tumor related factors. The patient factors include a patient around 40 years old or younger, an individual who you think would have a high likelihood of achieving pregnancy. The second is that they actually desire future fertility. Tumor factors in general, your tumor should be around 2 centimeters or less in size. And ideally, you would have a low risk histology, something that doesn't have a very high rate of recurrence when it's local. No evidence of spread to your lymph nodes, no evidence of spread beyond the lymph node, known as metastatic disease. And ideally, particularly for the first procedure, the tumor should be around 1 centimeter from the internal os of the cervix. The standard historical procedure, one of my favorite surgeries to perform, is a radical trachelectomy. Now, the radical trachelectomy involves removing, here you see the cervix, which is attached to the vagina. So you remove the tissue surrounding the cervix, which is called the perimetrium, the cervix itself, approximately 1 centimeter from the internal os of the cervix, and then the proximal vagina. In this picture you see, it's showing the blade amputating the cervix with the tumor from the uterus. And then you put what's called a cerclage around the residual cervix in order to, when a patient does become pregnant down the road, it helps that cervix have more integrity and more strength. And then you re-anastomose, or put the cervix back into the vagina. This is a picture of one of my patient's specimens. You can see the cervix here with the distal or the proximal vagina, and then the perimetrial tissue, or the tissue that surrounds the cervix. Here, a picture you can see where she has, the cervix has been amputated or removed, the tumor's all out, and then this is re-anastomosing the cervix, the residual cervix, to the vagina. And then this last picture here, it looks like we were never even in there. You know, it's a very nice outcome at the end. These radical trachelectomies, they're big procedures. They require open surgery. A majority of women who attempt pregnancy after a radical trachelectomy are successful, over 50%, around 70% is actually the number. And a majority of babies who are delivered do deliver at full term. So a great option for patients who have needed it over the past couple of decades, and excited now that fewer of our patients actually will need this procedure based on new trial data that we have. So that data it started with the CONSERVE trial, which was published in 2021. It really asked the question, is less more? And essentially it said, do we really need to do a radical trachelectomy on all patients with local cervical cancer? Instead, can we do what's called a cold knife cone biopsy, where you remove a cone-shaped portion of the cervix, including the tumor, with a negative tumor-free margin around that, around the tumor? In order to be eligible for the conserved trial, the patient factors are simple. They just have to desire future fertility. And then the tumor factors, as you can see, are a bit more extensive, and there's a reason for that. This is a less radical procedure, so you want to be as safe as possible with the patients that you select for this procedure. In the trial, the factors included a tumor less than 2 centimeters or equal to. It could not invade more than 1 centimeter into the cervix. No early signs of lymph node invasion, lymphovascular space invasion could be present. If it's an adenocarcinoma, it could be a grade 1 or 2, a squamous cell carcinoma, any grade, no evidence of lymph node disease, no evidence of metastatic disease. And you have to achieve if you don't achieve a negative margin on your first cone, you can do an additional cone and you'd have to achieve it then. So in this slide here, there were 100 patients who were enrolled in the trial, and really the column that we care about is this fertility preserving column, which were 44 patients who wanted to preserve their fertility. For all patients, you do have to assess their lymph node status. And in these 44 patients, 2 of those patients did have positive lymph nodes, and so they would need alternate treatment and weren't candidates for conservative management or fertility sparing management. And then only 1 patient ended up having a recurrence, which we'll talk about in a minute. These other 2 columns are patients who ended up not wanting fertility, who had a hysterectomy either after being enrolled in the trial or they had a hysterectomy and would have met criteria otherwise for the trial, and so they were also followed. So now the results, 5% of patients overall had positive lymph nodes, which is what we would expect. 3-year follow-up, there was in the overall population, 3.5% recurred. In the fertility preserving population of patients, there was only 1 patient who recurred of those 44, and that patient actually did not meet the eligibility criteria that I presented for you. That patient had 13 millimeters of invasion on their cone, and based on this patient alone, they actually modified the trial in the middle of the trial so that only those who had less than 10 millimeters of invasion could be included. And no patients who had less than 10 millimeters of invasion did develop a recurrence, which really suggests that that's the right cutoff for eligibility. Again, low rate of recurrence with your depth of invasion less than 10 millimeters. So this trial really told us that select patients with early stage low risk cervical cancer can be offered conservative fertility sparing surgery for their disease. So that was a conserved trial. There's another trial that is still not published, but it was presented at our annual meeting this year, the Society of Gynecologic Oncology, and it was GOG 278. It was a very similar trial to conserve, the only difference being it actually included patients with stage 1A1 disease who had positive lymphovascular invasion. That was really the only difference there. The other big difference is that it included measures of quality of life as their primary outcome, which is very rare in a trial. That arm wasn't as relevant for the fertility preserving group, so I won't really present that. But what was important here is that they had a fertility preserving arm. It was the same criteria where you would get a cone biopsy. If you did not have a negative margin, you would get an additional cone biopsy, and everyone would have to have their lymph nodes assessed. And they were followed very closely postoperatively. If you see, this is the only difference between the conserve and the GOG 248 trial is just the lymphovascular space invasion that was present. Also, adenocarcinomas at any grade, so grade 3 adenocarcinomas were still an option for the GOG 278 trial. Sort of broadens your inclusion criteria. 244 patients total were enrolled in this trial. 72 actually desired fertility preservation, and that's the population that we actually care about. Overall, 68 eligible patients were eligible for the survival analysis. So in this trial, they looked at, did these patients who had the more conservative approach have any differences in survival, and also what were their fertility outcomes? And so we'll go right to that. When you looked at these patients and their survival, 3 patients in the cone group ultimately had a recurrence. Which makes you think, in the conserved trial, only 1 patient, and that was the patient who had greater than 10 millimeters of depth of invasion. And here, you had the patients who had lymphovascular space invasion included. And so many will not include those patients based on this. And there were no deaths related to cancer in this study. And what were the fertility outcomes? The fertility outcomes were very good. 31 patients desired pregnancy during the time of the study. 15 of those patients were able to become pregnant and have, 12 of those patients actually delivered live babies. 9 of them were delivered at term, 3 of them were delivered preterm, and 4 were spontaneous abortions. So this suggests that this is a good option for patients who want to preserve their fertility. So in conclusion, from those 2 trials, we know that patients treated with a cone biopsy and pelvic lymph node assessment can achieve successful fertility outcomes, and that recurrences or the cancer coming back in the cervix after you have more conservative management can occur, and it requires very diligent surveillance to achieve a high cure rate through subsequent surgery. So for any of my patients who have fertility sparing approaches, as a part of me offering the procedure to you, you have to agree to close follow-up every 3 months, and you'd have to come into the office and get imaging for the first 2 years at least. That's sort of part of keeping you safe. So that's really the update that I wanted to share with respect to gynecologic cancers. There are other treatments for endometrial cancer that are fertility preserving, nothing novel or exciting like these studies. And ovarian cancer, really nothing new has happened on that front either, but we still offer options for patients who are safe to offer those options to. And so now a different topic, which is a little bit more exciting in my opinion, which is fertility sparing management of non-gynecologic cancers, like the cancers treated by Dr. Safar. So uterine transposition is really the topic that I wanted to share today. The uterus, as Dr. Safar mentioned, the ovaries themselves, they will potentially go into failure if they're exposed to 15 gray of radiation. The maximally tolerated dose to the uterus and to the cervix is slightly higher, around 20 gray. And by contrast, the dose used for radiation treatment for rectal cancer is approximately 50 gray, which is significantly higher. And the concern here is that once the uterus has been radiated, it can no longer expand the way that a normal uterus expands. And so even if a patient is able to get, to have their embryo implant and grow a fetus, grow a baby in the uterus can't really expand in the same way. And so it's likely that she'll suffer a miscarriage or a very, very premature child will be born. So we think it's not safe if you are exposed to this degree of radiation to carry a pregnancy. And so there's this novel procedure called a uterine transposition, where you temporarily place the uterus in the upper abdomen in order to allow a woman to receive radiation in the pelvis to ideally cure her rectal cancer or pelvic sarcoma cancer. And then after completion of treatment, you put the uterus back into its position so that a woman can get pregnant, through natural means. This is an option for patients who are good candidates for this, of course, with rectal cancers or pelvic sarcomas. The eligibility criteria that we consider is age under 40, again, someone who has a high likelihood of becoming pregnant and having offspring. BMI has to be around 35 or less. That's not a hard cutoff. The uterus needs to be of normal size. When you move the uterus up in the abdomen, someone who has significant or large fibroids, it would lead to a very heavy uterus, and so there may be complications related to that. There has to be no obvious evidence of endometriosis or significant scarring of the uterus that would make the surgery more complicated. And of course, the cancer cannot involve the uterus, cervix, vagina, or ovaries, as all of these parts are mobilized to the upper abdomen. Of course, this involves a conversation with the surgical oncologist, your colorectal surgeon, your sarcoma surgeon, and also the radiation oncologist is a part of planning. It's a multidisciplinary approach. The technique, again, you have the uterus here with the vagina, you detach it. You can either do this. This is basically a procedure where you can fix the uterus high up in the abdomen in order to allow for less exposure to radiation. But the procedure that we perform at NYU is a transposition procedure where you actually detach the uterus from the vagina and mobilize it to the upper abdomen. Considerations are very important. This is a novel procedure. There's limited safety data published, so any patient who's going to be a candidate for this has to understand that, of course. There's been under 50 procedures performed worldwide, yet there have been 3 live births to date. So this is a very exciting service that we offer for our patients here. And if it's something that can be an option to you or a loved one, definitely speak to your colorectal surgeon about it. because we do offer it. We also have this oncofertility program at NYU. It started in January of this year. Essentially, all patients who are diagnosed with cancer or any high-risk genetic mutation will have access to our specialized fertility nurse navigation program. Rose Semler is a nurse specialist who's been working in fertility for over 20 years. She and Vanji Mora run the program. Essentially, if your provider or you would like for them to assist with counseling or navigating fertility services during your cancer treatment or in the process of determining what how you would like to manage your high risk genetic mutations, they essentially a referral is placed for the service, and they'll call you within 48 hours and really offer you a host of services and navigation that is so tremendously helpful. They will refer you to services, make it very easy for you. They'll coordinate conversations between all of your providers. And they also can help you apply for financial assistance and philanthropy, as these services can be very expensive. And there are a lot of opportunities for aid that you may not be aware of, but that they are very aware of and can help with. So we're very excited about this program, being able to offer it to our patients and to sort of ease that very challenging process at a very vulnerable time in their lives. Thank you for listening, and happy to answer any questions at the end.
Good evening. I'm Deanna Gerber. I am a GYN oncologist at NYU Long Island, and I have a very special interest in high-risk genetics and early onset cancers. And so I'll be talking to you a little bit about that. So in the United States, there are millions of people who have a hereditary cancer gene. What this means is there's an inherited susceptibility to cancer. So it's passed down from one of your parents, and you can then pass it down to others. The most common known ones are BRCA and Lynch syndrome. BRCA mutations, or BRCA, are present in about 1 in 400 individuals in our country. In certain populations, such as the Ashkenazi Jewish population, it's present in 1 in 40 people. And Lynch syndrome is present in about 1 in 300 individuals. So the first thing that will happen is, you need to figure out your risk. Whenever anyone asks me, any patient or any family member asks me what the best thing that you can do to advocate for yourself in the medical system, it's to know your family history. And so the first thing will be your doctor will obtain a comprehensive personal and family history. So if you have any history of cancer, or anyone in your family has any history of cancer, that's something that you will want to share with your doctor, and your doctor should be asking. And then with this, approximately 30% of the population will have an elevated lifetime risk for cancer, which will then warrant referral to genetic counseling and possibly genetic testing. And of those, will then get genetic testing. But approximately 1 to 5% will have an inherited hereditary cancer syndrome, and an additional 10% will have just an elevated lifetime risk for breast cancer. And this is kind of one of the newest breakthroughs in our genetic testing, is even without a specific genetic mutation, we're now getting results that tell you if people have an increased risk over their lifetime in the absence of a mutation. So why is this important information? What can we glean from knowing this information? So I'll start with BRCA mutation. It's kind of the most well-known. Angelina Jolie was diagnosed with a BRCA mutation many years ago and kind of brought it to the public eye. So the BRCA mutation is inherited. You have a 50% chance of inheriting it if one of your parents has it. The risk of inheriting a breast cancer, of developing a breast cancer with a BRCA mutation, is up to 70%. The risk of developing an ovarian cancer, depending on the mutation, is 20 to 40%. Pancreatic cancer is 5 to 10%, and prostate cancer is 30%. So these are very high percentages. And this is much higher than we would see the rates in the general population, or meaning everyone, if we included every person without a genetic susceptibility. And then Lynch syndrome, which Dr. Safar also mentioned before, is a generally thought of as a colorectal cancer susceptibility gene, but with certain mutations of the Lynch syndrome variety, there's a 60% risk of developing colon cancer. What I guess some people may not know is there's also almost an equal risk in women of developing a uterine cancer with Lynch syndrome, a high risk of developing ovarian cancer, depending on which Lynch syndrome gene mutation you have, and then gastric cancer. So the common belief is that genetic testing may provide worrisome information on cancer risk. And that is absolutely true, but it doesn't just have to be worrisome. There's a lot that we can do with that information. So once someone is diagnosed with a hereditary cancer syndrome with one of these genetic mutations, it can trigger this whole cascade of personalized medicine. So for instance, with a BRCA mutation, if you're diagnosed with one, you can take birth control pills or oral contraceptive pills, and that can decrease your risk of developing a breast cancer. Also, as Dr. Gemignani mentioned before, mammogram is generally recommended at age 40 for the general public, but if you have a genetic susceptibility, you might be recommended to get an MRI at an earlier age, sometimes starting at 25, even earlier in some. And then in addition to mammogram, you may be also recommended to get an MRI of your pancreas or of your breast to also assess your risk. There's also surgery that you could be recommended to diminish or greatly reduce your risk of developing a cancer. In gynecologic cancer, we can remove your ovaries or fallopian tubes to decrease your risk of developing an ovarian cancer. And there's other surgeries and other specialties as well. And then you could be offered an endoscopy or a colonoscopy, which can give you closer surveillance of developing the risk. And as Dr. Safar mentioned before, normally we're recommending colonoscopy at age 50, but in people with a known genetic susceptibility or hereditary cancer risk, we would be recommending it much earlier. So again, if you have 10 women, like we said before, mammogram would start at age 40. But we know that approximately 1 in 10 women will have an elevated lifetime risk of breast cancer. And so then they might be recommended an MRI. And so this really shows you, how personalized this medicine can be. So while we know that increased surveillance or increased screening, so increased mammogram plus MRI alternating, may not prevent a cancer, it will lead to improved outcomes such as earlier diagnosis of a breast cancer, so more likely to be diagnosed as a stage 1. And the stages of cancer are generally thought to correlate with their prognosis. So diagnosing something as a stage 1 is usually better than diagnosing it as a stage 3 or 4, and usually matches up directly with the prognosis and the outcomes. Also, if you're having this personalized breast cancer screening, you're more likely to have a smaller tumor size and, like I mentioned, improved survival. So personalized medicine is really kind of the goal with genetic testing. And so genetic testing, I think, has a bad rap in the general public eye, but genetic testing has really changed over the past 3 decades. So the first genetic cancer syndrome was kind of identified in 1900 with the Lynch syndrome family. But we didn't have the technology or the ability to test for genetic mutations until the 1990s. So in the 1990s, the BRCA mutations and the Lynch syndrome mutations were identified. At that time, we were doing just very specific testing, looking for specific mutations, and the cost to the patient was very expensive. It was over $3,000. There's also been a lot that goes on. So previously, if you were known to have a genetic susceptibility to cancer, if you knew that you had a 70% risk of developing breast cancer, that would affect your employability. That could affect your ability to get health insurance, your ability to get life insurance, and the rates would be increased. But with the GINA, or the Genetic Information Non-Discrimination Act, which was passed in 2008, it is now illegal to discriminate based on those things. And so that's a huge breakthrough in genetic testing and, you know, management of hereditary cancer syndromes. Now, we are testing for many, many genes. I'll show you on the next slide how many genes we can be testing for that have an actionable mutation, that have something that we can do to prevent a subsequent cancer. And the cost is now much more affordable. It's still $250 at most, but which is expensive, but much improved compared to the over $300,000 that was previous to that. When it comes to multi-gene panel testing, it's when we test many, many genes with one blood test or one saliva test. And it has given us so much more access to lesser known mutations that families may be passing on, or patients with cancer, or, you know, family members of people with cancer may, you know, inherit. And so this is just like a example of all the genes. The ones in yellow are ones we test for with breast cancer. These are the common breast cancer genes, but the rest of them are tested on these multi-gene panel testing. And so with multi-gene panel testing, we've been able to kind of get more information on these lesser known mutations, such as PALB2. PALB2 is in the same family as a BRCA mutation, but not as commonly known. But it has a very similar risk of developing a breast cancer, a lesser risk of developing an ovarian cancer, but a high risk of developing pancreatic cancer and even male breast cancer. And, you know, the New York Times a few years ago published an article kind of bringing awareness to this mutation. And so helping people advocate for themselves when they don't have just the well-known BRCA mutation, a multi-gene panel testing may be beneficial. So again, back to this slide, millions of people in the United States have a hereditary cancer gene, but the majority of those who have one of these genes are not aware and have not undergone testing or do not have a diagnosis. And this is a huge area for improvement. And so why is that? So the old process of genetic testing used to be that a physician would get the family history, which we still should be doing. We would then decide if you met the criteria for genetic testing. We would then refer you out to a genetic counselor, which is still very commonly done. But the wait time for genetic counselor appointment was very long, and the genetic testing took very long time to complete. And this is kind of the barriers. At every step there could be a barrier. So at NYU, how are we improving the process of genetic testing? There's a few things that we're doing. So one thing we're doing is point of care testing. So at the second part where your medical team is collecting a comprehensive family history, and your doctor is determining if you meet criteria for genetic testing by asking all these questions about your family history. And so these are just some examples of what might trigger your medical team to think, does this person sitting in front of me meet criteria for genetic testing? And so what we're doing now is point of care testing. So if you meet any of these criteria for a high risk cancer syndrome in your family or in yourself, we will then do the genetic testing in the office that day if it's available in your doctor's office. And so that's getting people quicker access to the genetic testing results so that we can intervene earlier. Another thing that's so useful about knowing about your genetic mutation is cascade testing. And so what cascade testing means is the person who is diagnosed with a mutation, we call them the proband, will then, we know that they have a 50% chance of passing it down to their children for most mutations. Also, if they have it, their siblings may have it, or their parents may have it. And so it's called cascade testing because it starts a cascade of testing in your loved ones and your family. And so we figure out the person who's at risk, and then we test all the subsequent generations. And that can then lead to people knowing about their cancer susceptibility gene before they develop a cancer, and they can do all of those things to prevent a cancer. And so these are really the benefits of, our high-risk genetics program and knowing about these mutations. So in summary, hereditary cancer syndromes are common but under-recognized. Genetic testing is more comprehensive and cost-effective than ever before. However, most people at risk for these hereditary cancers have not been tested. What we are doing here at NYU is we're working to increase patient access to potentially life-saving genetic medicine, personalized medicine, and we're going to do whatever we can to increase your risk, to increase your testing and decrease your risk. So thank you, and I believe now we will open up for the Q&A.
Look, the hemorrhoids are very common in pregnancy, and is there any link to cancer? Absolutely not. What I would say is, if you start bleeding and bleeding a lot per rectum, then I think, you should have a colonoscopy at some point. After things are settled, and most of the time things don't get to come to a head through the pregnancy. But I think bleeding is bleeding. I don't think the two are linked. It's just that when you have hemorrhoids, because you're pregnant or not pregnant, and then you just say, oh, it's just hemorrhoids, you should not ignore the bleeding. That's what I would say. They're not linked. One doesn't lead to the other. But unfortunately, we've had a number of patients who've come in with worsening constipation through pregnancy or bleeding through pregnancy that ends up being a little bit more than just hemorrhoids. I think you should see someone if you have bleeding. It's a very interesting study. It came out of Sweden, and it's a population study. There was only 15% of those patients that were 45 to 49. But nonetheless, they showed that if you don't have a family history, and in Sweden, it's a very homogeneous population, and they don't move. So they can track patients well, and they know their family histories well, and it's a much different population. So I don't know how easy to translate this data to the United States. And I don't think it's going to change from 10 to 15 anytime soon, but there's something to it. My biggest issue is actually if you have symptoms, and even if your colonoscopy was normal a year ago or 2 years ago, and if you have bleeding that keeps going on or a change in bowel habit, go push for another colonoscopy, more so than the stretching. If you're normal, you have no family history, you can debate whether 10 or 15 is okay. But even if it was normal and you've developed new symptoms in a shorter space of time than you were told to go back, go push for a sooner colonoscopy. That's what I would like to emphasize.
Gynecologic cancers, I'll answer it. And the answer is no. There's no modification in your risk of recurrence based on age alone.
I'll take it for colorectal. So again, back to rectal. The reason rectum is different to colon is, I don't know if I emphasized it enough, sometimes to reduce the local recurrence, we give radiation, and that's what affects the other stuff that's going on. And then we give chemo. Everything in the cancer world depends on stage. If the stage, especially locally, is advanced, then there's a high risk of recurrence, young or old. If the stage is early, then it's not. So, again, the earlier somebody presents, the better off we all are. From a treatment standpoint, it's easier. From a surgical standpoint, it's easier, and the cure rate is high. If it's advanced, then I don't think it's related to age. I think it's the stage that determines it.
Yeah, I think also for breast, it goes down to what we were talking about, that women get diagnosed at a more advanced stage because they're not getting screened, because they're not meeting the guidelines, or they're ignoring symptoms, sort of like what we talked about for colon. And so it gets confounded. So people think that the age is what's affecting the outcome. And yes, but age is associated with worse kinds of cancers and a later presentation. So in a lot of the studies, once you control for those factors, then you see that it's not really independent. So the answer is probably no. It has to do more with the cancer that the person has than it does about their risk of not doing well from it.
I'm sitting on KP10 right now. My background is the
I
patient's
love it.
background.
Yes.
So I hope you don't have to get treated for anything, but this is how nice the Kimmel rooms are. So
But I do
thank you
have to
for joining
say,
us.
you know, we have such great teams of doctors and all of the imaging and everything, and everyone here works really well together. So I think that's important when you're thinking about picking a place to go and for screening, or even just to meet with one of us should you ever need to have any treatment for a particular problem. So it's a pleasure being here tonight, and I want to thank you all for participating, and the rest of the panel also.